All right. Let's go with the next topic here. What do we have? It is idiopathic intracranial hypertension, also called pseudotumor cerebri. There is an increase. So to pseudotumor cerebri, what are the features? So you would have an increase in ICP, intracranial pressure, with an increase in intracranial pressure with no obvious structural findings on imaging. Risk factors include female sex, tetracycline, obesity, vitamin A excess, and danazole. So the good mnemonic here is a female toad, or you can say female acne toad. So here's you got the female sex acne. Treatment of acne is tetracycline, oral tetracycline, right? I mean, that's one of the step of the treatment. And obesity is the toad, all the toad. So you have O for obesity, A for vitamin A excess, and D for danazole. So these are all the risk factors. It is associated with dural venous sinus stenosis. Findings are headache. Of course, when you have increase in ICP, of course, you're going to get headache, right? Headache exacerbated when lying down. So this is important. Headache, when you are lying down, you get more and more exacerbation of that headache. So basically, it's going to also worsen with Valsalva. So one thing is this thing. On top of that, they might mention Valsalva would worsen the headache. And also lying down also worsens the headache. And then you have the tinnitus diplopia. Diplopia is usually from the cranial nerve 6 palsy. And we will talk about that one. Just keep in mind at the moment. No change in mental status. Impaired optic nerve exoplasmic flow leading to papilledema. So again, CN2 is also involved. Visual field testing shows enlarged blind spot and peripheral constriction. LP would reveal increase in opening pressure and provides temporary headache relief. So as soon as you do an LP, first of all, you're going to have increase in pressure that will provide temporary headache relief at that time. What are the treatments for this? Treatments are weight loss, acetazolamide, invasive procedures for refractory cases, example, CSF shunt placement. So CSF shunt is what's going to decrease the pressure in the CSF. It's going to drain the CSF, so you don't have a lot of CSF, causing increase in ICP. You're trying to decrease that ICP. Acetazolamide doesn't let you make a lot of CSF. And you can also do in refractory cases. You can just give the shunt placement, optic nerve sheath fenestration surgery for visual loss. That's another thing. So, what are the important things and what should we know for this tumor? Idiopathic intracranial hypertension. So here, all we have to know is this female toad. Female toad, female sex with acne and toad, meaning tetracycline, obesity, vitamin X, and danazole. They will develop this intracranial hypertension. How would you know what it is? Because of the clinical features. You will have clinical features of increase in ICP. So what are the features of ICP? Again, you will have headache. You will have headache. Again, they haven't mentioned here, but vomiting, drowsiness, nausea could also be associated with it. On top of that, you will also have papilledema. That's going to be there. So two nerves that it affect are going to be because you are increasing the ICP, that's going to compress two cranial nerves here. If it was to compress CNS2, it's externally again. So let's just mention CNS2 here. CNS2 cranial nerve. So one thing about CNS2 is it has if you compress it externally, like the external part of this cranial nerve 2, you are going to get impaired. Where is it? Impaired optic nerve exoplasmic flow, which will lead to papilledema. So here, because you have increase in ICP, and that CSF is just going to push on this nerve CN2, causing impaired exoplasmic flow causing papilledema. And the second nerve we talked about is CNS6. CNS6 will give you is diplopia. Where is it? Headache, tinnitus, here you go, diplopia from the CNS6 palsy. Okay, so let's just erase this and recall the whole thing and move on to the next. So the very easy topic is idiopathic intracranial hypertension, also known as pseudo-tumor cerebri, increase in ICP with no structural findings on imaging. Risk factors, again, female toad. Findings going to be headache, cranial of 6 palsy causing diplopia, CN2 impairment causing papilledema, visual field will show enlarged blind spot and peripheral constriction, and LP high yield. This is LP shows will reveal increase in opening pressure, and that would temporarily relieve the headache. Treatment is also high yield. You want to try to decrease these risk factors somehow. So weight loss is one of the things. Acetazolamide and then CSF shunting could be placed for this. And that is going to be all for this one. Now moving on to hydrocephalus. Hydrocephalus. So here all you have is you have increase in CSF volume. Somehow, we will figure that out. Why would you have this CSF volume high? But somehow just remember hydrocephalus increase in CSF volume. That leads to ventromegaly, which is known as ventricular dilation for sure. That would either increase or not increase ICP. And why are we saying not increase in IPCP? That's just called normal pressure hydrocephalus. That's only one of the things. But just generally, you're looking at increase in CSF causing ventricular dilation, right? So why would you have this increase in CSF? So either, if you just think about it, either you have increase in production of CSF. That's why you have total increase in volume. So increased production, let's just say it that way. Or you have impaired drainage, right? So if you increase it in production, it's going to cause increase in total CSF volume, or you can't drain it, it's going to cause increase in CSF volume. So let's take a look at each one of the diseases now. So here, let's just change color. So we have communicating, non-communicating, and hydrocephalus mimics, which is ex vacuo. So in the communicating one, as the name suggests, so that means communication is there, meaning there is no obstruction. While here you have an obstruction. So let's just talk about each one of them. Communicating hydrocephalus, all you have is a decreased absorption by the arachnoid granulations. If you recall, arachnoid granulations were the one which CSF would go through granulations in order to go into the veins, internal jugular vein, right? So here, all you have is the CSF cannot be absorbed by arachnoid granulation. And why is that? Because of scarring of these arachnoid granulation. Why would you have scarring? Because of post-meningitis. There was infection lead to scarring lead to, you can't absorb CSF. Because if this was the arachnoid granulation, CSF has to go through it. There is a scarring here now. Not a lot of CSF can go through it. So causing decrease in CSF absorption, simple as that, right? Which would cause what? Increase in ICP, for sure. And that would lead to papilledema. Herniation is also there. All ventricles are dilated because there is no specific point where the communication is lost. So this one is communicating hydrocephalus, meaning all the communications are intact. It is not obstructive. All the communications are there except that the distal point is just scarring. And that leads to decrease in absorption by the arachnoid granulation. So CSF is being made and sent into this subarachnoid space, but it cannot get reabsorbed, so leading to high level of CSF, causing increase in ICP, and causing papilledema, herniation, and ventricular enlargement, simple. Then you have the normal pressure. Let's change color here. Normal pressure hydrocephalus. It affects older adults, idiopathic, CSF. CSF pressure elevated only episodically. Important that the CSF pressure is not high all the time. It is only episodically increased. It does not result in increased subarachnoid space volume. Expansion of ventricles. Looking at picture A, we have the expansion of ventricles. If you take a look here, which would distort the fibers of corona radiata, right? Corona radiata, if you think about it, it was running all the way here. So it's going to distort those fibers, leading to triad of gait apraxia, which is a magnetic gait, cognitive dysfunction, urinary incontinence. The high yield mnemonic here is, which is pretty good to remember, is wobbly, vacky, and wet. So you have a gait problem, wobbly, wet, you have a urinary incontinence, and vacky, you have cognitive dysfunction. Okay. And the treatment, all you have is you could have a CSF drainage via LP, which is lumbar puncture, or shunt placement that would fix the problem. So let's just quickly go through this one, which is a pretty easy to know. First of all, with normal pressure, you always going to see it in older adults. Older adults, you're going to look at, it's called NPH, normal pressure hydrocephalus, where the patient, with an old patient, is going to come with urinary incontinence, cognitive dysfunction, gait apraxia, which is magnetic gait. So wobbly, wacky, wet, and you would right away think, okay, maybe it's due to normal pressure hydrocephalus. Because when you do look at the pressure, it's only episodically increased, meaning you check the pressure, it's not increased at that time. Let's say if you check it. So that's one of the things with normal pressure hydrocephalus. So let's just dive into some more features of this. So NPH, let's just put it here, NPH. NPH causes, we know it's going to cause a couple of things, right? So as the earlier disease of NPH, which is normal pressure hydrocephalus, it will appear earlier in the disease. All you're going to get is the gait problems. So gait difficulties, let's just put it that way. What are the gait difficulties the older adult is going to have? The older adult will come with slow, short steps. Slow, short steps with decrease in height. So very slow, short. So as they mentioned right up top, is the magnetic gait, as if the magnet is there under their feet. So they can't have a proper height of the step. So they have a short steps with decrease in height because of magnet being attached. Just imagine there's a magnet there under the feet. Okay. Also, as I just said, it's like feet may appear as though they are stuck to the ground, magnetic gait. On top of that, you will also get upper motor neuron lesion sign symptoms. Upper motor neuron lesion sign symptoms. For example, what are those? Increase in reflexes, hyperreflexia, which is known as hyperreflexia, and spasticity, spastic paralysis, spasticity. So that's only one thing. And this is the earliest. With NPH, this is the earliest finding. A couple more features of this is we also have later on what we are going to see is the cognitive disturbances, which is the patient will come with difficulty concentrating and apathy. So difficulty in concentration plus apathy. And lastly, what do you have is called urinary incontinence. And urinary incontinence is, if you just think about it, normal micturition center regulates the micturition reflex, right? Which is an autonomic spinal reflex mediated by neurons in the sacral spinal cord. Again, micturition reflex is an autonomic. It is an autonomic reflex which is mediated by neurons in the sacral spinal cord. Now, in NPH, what's going to happen is that you have a loss of, because if you remember this, we are talking about sacral spinal cord. We didn't mess this up, right? So why do we have urinary incontinence in these patients? We have urinary incontinence in these patients because we have a loss or lack of cortical inhibition of the sacral micturition reflex. So this sacral micturition reflex, it is normally inhibited by the cortex. But when you have the loss or a lack of that cortical inhibition of this micturition reflex, the patient will undergo urinary incontinence, which is the urge incontinence. They will have urge to go to the bathroom to pee, urge incontinence. Okay, so this is behind this. And this, it will get worsened by the gait problem. So already they can't walk, first of all, and already they're going into urge incontinence. Just imagine what a terrible thing is going to be. Urge incontinence, running to the bathroom, but they can't walk. So it's really, it limits the patient's ability to rush to the bathroom, right? Leading to urge incontinence being there. And this is a very high yield point on this. Other than that, this cognitive dysfunction would also lead to dementia. And that's going to be all. So let's just review this. So normal pressure, when you do the LP, it's going to show plus minus normal. LP would show normal opening pressure first thing. So let's just mention here. LP, normal opening pressure, one thing. Second thing is going to be you have either increase and not increase in CSF. So intracranial pressure is going to be plus minus normal, meaning episodically it is increased, but maybe when you check it, it's normal. You don't know, right? That's the second thing. And it's just that with these signs and symptoms, you can say, okay, but also when you do the imaging, you will see high yield, which is that expansion of ventricles will be seen. Patient with wobbly, vecky, wet, gait apraxia, cognitive dysfunction, urinary incontinence. And that is all for normal pressure hydrocephalus. So let's just review these two first, and then we can move on to the next. So what did we talk about here? We said for communicating in normal pressure hydrocephalus, all we talked about is there is a decrease in CSF absorption. Decrease in CSF absorption. Okay. And then next is we have non-communicating, which is also known as obstructive hydrocephalus. Here all we have is there's only one type, which is same thing as above, which is non-communicating hydrocephalus. It is typically congenital. See, it's a structural block, so it's a typically congenital. So there is a structural blockade of CSF circulation within a ventricular system. For example, stenosis of the aqueduct of Sylvius, the colloid cyst block in the foramen of Monro, or the tumor. Look into picture B. You can see in picture B, there's a proper space occupying lesion, a tumor. So ventricles upstream of the obstruction are dilated. So wherever the obstruction is, it could be stenosis of the aqueduct of Sylvius or the foramen of Monro, wherever the obstruction is, and whatever is draining towards that area, it's going to get dilated. Let's say there's obstruction here, it's going to get dilated. But if there's obstruction here, the whole thing is going to get dilated, depending on where the obstruction is. Okay? And that is the non-communicating hydrocephalus. With its tumor being there, tumor is also going to do the same thing as the meningitis did. For example, this tumor is going to block as a space-occupying lesion, right? You can also see non-communicating hydrocephalus with infections. And infections, you already know what's going to cause. It's going to cause scarring. Or you can also see after the hemorrhage, post-hemorrhage, what's going to hemorrhage is going to do is going to block these areas of the foramens, right? Okay, so now let's just take a look at if we were to block this foramen of Monro, if you recall normal anatomy here, if you block the foramen of Monro, you're going to get the enlargement of the lateral and third ventricle, right? So if you recall, what is the Monro, right? So the Monro was draining, there are two foramens. They were draining the foramen of Monro and Magendie, right? All right, so that's going to be all. So here, like we said, this is going to be something congenital, right? You have a structural block congenitally. If you have a patient who's older adult, you're going to think about NPH. With the communicating hydrocephalus, you're going to think about either an infant or child with decrease in CSF absorption. Okay, specifically after meningitis. So let's dive into a little bit of this congenital hydrocephalus a little bit more. So congenital hydrocephalus, this is actually right here. Congenital hydrocephalus. It is again decreased, it is impaired CSF drainage due to either, you have two factors, either congenital obstruction, in which case you have this aqueductal stenosis or Chiari-Denny malformations, all that, right? Or you could have an acquired obstruction, specifically after post-infection, in the with the meningitis, toxoplasmosis, and CMV. So let's just write CMV, toxoplasmosis, and meningitis as common thing. And this all sign and symptoms of this congenital hydrocephalus or high yield. The patient will present with macrocephaly, enlarged head, bulging fontanelle, poor feeding, and developmental delay with muscle hypertonicity, hyperreflexia. Again, why hyperreflexia? Due to upper motor neuron lesion caused by the stretching of periventricular motor pyramidal tracts. And periventricular basically means when you enlarge the ventricle, right? So let's say this is a ventricle. You enlarge these ventricles. What's going to happen is periventricular, on the side of the ventricles, you have the pyramidal tracts that run through it. Now, these pyramidal tracts are going to get compressed. And when you compress those tracts, you're going to get an upper motor neuron lesion, calling all the sign and symptom of upper motor neuron lesion, like for example, hyperreflexia, spasticity, all that. Okay, muscle hypertonicity. And also they will also present with eventually developmental delays and seizures. So treatment for congenital hydrocephalus is going to be shunt, VP shunt to bypass this obstruction. Okay, so we just dive in a little bit extra topic, which is not mentioned here, but you will see that. So the only high yield about this congenital hydrocephalus you will see is, again, very high yield macrocephaly, big head, enlarged head, and also bulging fontanelle. Bulging of fontanelle with all these features, an upper motor neuron lesion, you will think about is a congenital hydrocephalus. Okay, and that is going to be all for this one. Let's move on to the next one, which is hydrocephalus mimics, which is ex vacuo ventromegaly. All this is about it. There is an increase in CSF, appearance of increased CSF on imaging, but actually is due to decrease in brain tissue and neuronal atrophy. For example, Alzheimer's disease, HIV, frontotemporal dementia, Huntington disease. ICP is normal, and NPH triad is not seen. So in other cases, this is again an old patient with diseases. Either it is old patient. Huntington, you can have a range, but you're thinking about some old patient which has an increase in CSF. But let me just erase this. So it has an appearance of increase in CSF, but that's not due to increase in CSF, but other factors are because there is a decrease in brain tissue or atrophy, for example. So this is the skull, this is the brain. So you have a normal CSF here. But if you were to go into atrophy, let's just do this here. same skull, but the brain has atrophy. Now you will have more CSF because the fluid is going to fill up the space, right? So when you look at the imaging, you see increase in CSF, but that's not due to increased production or decrease in absorption, but it is only due to decrease in brain tissue. The tissue here, it has been atrophied. And why is that? Because of a chronic diseases like Alzheimer's disease, HIV, frontotemporal dementia, Huntington disease will all get ex-vacuum ventromegaly. And again, when you check the ICP, it's going to be normal because you have so much space over there. So ICP is normal. NPH triad is not seen. Okay. And that is going to be all for this one. Okay. So you will also see something if you look in picture C. There was an increase in CSF with increase in CSF, right? But the thing is here, you have, as you can see, ventromegaly, as you can see in the picture. So ventromegaly, meaning ventricles are enlarged, ventromegaly in proportion, it is proportionate to the sulci enlargement. So if you look at these sulci, they are enlarged. Okay, so this ventromegaly is going to be proportionate to your sulci enlargement. And why are these sulci enlarged? Because of the brain tissue being atrophied. Okay, due to atrophy, due to, again, neuronal atrophy. So what you will see is increase in size of sulci proportionate to the increase in the size of ventricles. That's on imaging, high yield. Okay, and that's all about ex-vacuum. So let's just recall the whole thing and move on to the next part. So we said, all right, let's now quickly go over this, the whole thing, and move on to the next. So all we talked about is idiopathic intracranial hypertension is all about a young woman with increase in ICP, with headaches. So you want to look at if you have a young woman with headaches, and when you check on the imaging, there's nothing, and there's an increase in ICP, you will think about idiopathic intracranial hypertension. Hydrocephalus, all about you have communicating hydrocephalus, in which case that the CSF is not being absorbed. When the CSF is not being absorbed, what's going to happen is you have increase in ICP. With the normal pressure hydrocephalus is an old age patient with Wabi-Vaki and which is gait apraxia, congenital cognitive dysfunction, and urinary incontinence, but plus minus increase in ICP because it is only episodically increased. Okay. Then you have the non-communicating, which is also known as obstructive. I mean, there is an obstruction. Wherever the obstruction is proximal to that obstruction, you can have ventromegaly. Okay, ventromegaly will be there. With the ex-vacuum, let's say it's an old patient with dementia type features, for example, Alzheimer's disease, HIV, frontotemporal dementia, Huntington disease, all that, with the ICP being normal. And it is proportionate increase of the sulci to the ventromegaly. And that's going to be all for hydrocephalus. Okay, now we're going to take a look at multiple sclerosis, high yield topic. Multiple sclerosis is an autoimmune inflammation and demyelination of CNS, in which case you have a brain and spinal cord with subsequent axonal damage. Most often affects the females age 20 to 40. High prevalence in individuals who grew up further from the equator and have decrease in serum vitamin D levels. And it can present with optic neuritis, which is acute painful monocular visual loss associated with relative afferent pupil defect, brainstem cerebellar syndrome, in which case you're going to get diplopia, ataxia, vertigo, scanning speed dysarthria, intensive tremors, nystagmus. High yield is this intranuclear ophthalmoplegia, INO, which is bilateral more than unilateral. So again, if you mess up your cerebellum, you're going to get all these features. And if you mess up your pyramidal tracts, demyelination will cause weakness and spasticity. We talked about it, how spasticity is an upper motor neuron lesion. In case, I mean, everything. So just, we'll talk about that. I think it's going to come up. But anything which affects the brain, CNS, or the spinal cord, anything which affects here is going to give us upper motor neuron lesion. And we have the specific features of that. Anything that goes from in the spinal cord all the way to the effector muscle, if wherever it's going, if we knock out that place, whatever is coming out of that spinal cord, we are going to get a lower motor neuron lesion. And there are specific features of that. We will talk about that. There's a full table coming up. And you have a spinal cord syndrome, which is electric shock-like sensation originating from cervical flexion transmitted along the spinal cord, which is called Lhermitte sign or Hermite sign. Neurological bladder, neurogenic bladder, paresthesis, sensory manifestation affecting the trunk or one or more extremities. Symptoms may be exaggerated by stressor. Important. There has to be a stressor which would exacerbate all these symptoms. And for example, the stressor could be heat, which is Uthoff phenomena. Exercise or infections, relapsing and remitting is most common clinical course. High yield, that it will relapse and remit. It will come and go, waxing and waning, sort of a feature. So let's talk about now more details into all of these things. Let's first of all mention some risk factors of MS, multiple sclerosis. So risk factor, again, if you look here, we have a young female, okay, with a young patient who could be living in a cold climate area, for example, area location in the USA, Europe, in which case they're not getting enough sun, or that they have a low levels of vitamin D, okay, and these are all the risk factors, right? Smoking is also the risk factor. Smoking. So with all these risk factors, all we have is an autoimmune. So it is an autoimmune disease. Now they'll ask, which type of autoimmune disease is this? So it is a type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction, which deals with two types of things. We have a T cell response plus macrophages response here, and also the antibody formation. Okay. And this autoimmune inflammation will cause demyelination of CNS. So now, if you recall, who was myelinating CNS, it was oligodendrocytes. So this autoimmune destruction is of oligodendrocytes, which leads to degradation of that myelin, right? And in the CNS, we have brain and spinal cord, but also on top of that, we also have cranial nerve 2 getting destroyed by it, right? With subsequent axonal damage. We talked about female high prevalence in individuals with grew up with a further away from the equator, meaning not getting enough sunlight, cold temperatures basically, right? Low vitamin D levels. We did talk about that. And one more thing which is not mentioned here is smoking, high yield, and one more important is the EBV infection, Epstein-Barr virus infection. So these are all the risk factors. Now, high yield point, how's the patient going to present? It's going to present with optic neuritis. What is optic neuritis? Optic neuritis is going to be a painful eye movement. Let me just put it, so they mentioned it, acute, painful. Whenever you move the eye, you have a pain. Acute, painful eye movements will give you monocular, only one side visual loss. And also, you have swelling of the optic disc. Swelling of the optic disc. Swelling of optic disc. So two things. Optic neuritis. First of all, you have this painful eye movements. Second thing, you have the swelling of the optic disc. Okay. With the brainstem, you will just think about some cerebellar syndrome, signs and symptoms, for example, ataxia, vertigo, scanning speed disorder. And you can take a look at that back in neuroanatomy, that what are these cerebellar signs and symptoms, for example, tension, tremor, nystagmus. More importantly, what you are going to think about here is the INO, which is intranuclear ophthalmoplegia, being affected, bilaterally affected, greater than unilateral. Now, because you are messing up your oligodendrocytes here, so pyramidal tracts will be demyelinated, right? It will cause weakness and spasticity. You will also get spinal cord syndrome, and these are all the features of that. Now, symptoms would be relapsing and remitting, high yield. What is relapsing and remitting? They will also mention that they are separated. Symptoms are separated in time and space. That's another wording for relapsing and remitting. Sort of a feature, which is just saying they're episodic. So these patients with MS will have an episodic neurological deficits. And these neurological deficits are going to be, again, separated in time and space. Okay. Let's look at the findings now. The findings of it are increase in IgG levels and myelin, basic protein in CSF, oligoclonal bands in CSF, aids in diagnosis. MRI is a gold standard. You will see periventricular plaques. Let's look at picture A. We have a ventricle here. Periventricle means on the side of the ventricle, we have plaques. Yes, we do see that, which are areas of oligodendrocyte loss and reactive gliosis. When you lose the oligodendrocyte, there's a reactive gliosis, which is seen as white, and that's the periventricular plaque. Now, multiple white matter lesions disseminated in space and time. Again, multiple white matter lesion will be there, disseminated in space and time, that they will be relapsing and remitting, coming back and forth. It will be fixed, and later on you will see them again. So it's not a fixed problem. Okay, what else you might see? So again, in the labs, what we will see on the LP, you have increase in IgG levels. When you look at in the CSF, you will see oligoclonal bands. Again, oligoclonal bands are all about, if you have, you will see oligoclonal band in any disease which causes increase in immunoglobulins within the CSF. So here we have increase in IgG causing oligoclonal bands in the CSF. Okay, and then what else you might have is periventricular plaques. And important thing is all about, let's talk about the gray and white matter. If you recall, the gray matter is gray. Let's just keep it here. Gray is gray because it has myelin. That's why it's gray. And white matter is white because there is no myelin. So here, if you take a look at this spot, you see you have this demyelination. Myelin would have given you a gray picture, but here it's all white because the myelin is destroyed. Okay, and that's why it's giving you in the periventricular plaque, they are the it will give you white areas on the sides of ventricle. Okay, now one extra thing on this, when you look at this histologically, this periventricular plaques are composed of T lymphocytes and macrophages, and when there's inflammation, they will disrupt the blood-brain barrier. When they disrupt the blood-brain barrier, more and more inflammatory cells will recruit, causing patchy demyelination and axons that are going to be spared. But there's only patchy demyelination of the patchy demyelination will be seen. That patchy demyelination is going to cause, because of demyelination, you have a significant disease that causes neuronal death, And that neuronal death, eventually the hyperplasia of the astrocytes will take place, and that will lead to formation of a scar. It's called glial scar, formed by astrocytes hyperplasia. That's one thing. Second thing, guess if you have a patch demyelination, again, if you recall, what was myelin doing? It was doing its saltatory conduction. So when you have destroyed the myelin. When you destroy the myelin, now what's going to happen is you have a decrease in that saltatory conduction because myelin is destroyed. Okay. And that myelin, when you destroy the myelin, now let's just talk about one more thing, is that it will slow the conduction. When you slow the conduction, now there is a full sodium channel. Over time, the sodium channel will eventually redistribute and across the naked axon, leading to surviving oligodendrocytes partially remyelinating neurons. So one thing is going to happen is that you will have, just recall one thing, that it will lead to remyelinating of axons. That remyelination will give you some restoration of signal transmission, right? And when you restore some signal transmission, what you are going to develop is some signs and symptoms of multiple sclerosis will resolve. And that is essentially what we say, waxing and waning signs and symptoms, meaning they will come and they will go. They will come back and go. Waxing and waning signs and symptoms. And that is all due to the effect of demyelination, and somehow that sodium channels redistribute, causing some signal transmission to go through even in partially damaged neurons, leading to resolving of the signs and symptoms of that multiple sclerosis. So that is there. Now on the treatment hand, what do we have for the treatment? Treatment is start the relapse and halt the progression with disease-modifying therapies, beta interferon, glatiramer, natalizumab. Treat the acute flare with IV steroids. Symptomatic treatment for neurogenic bladder by giving muscarinic antagonism, botulinum toxin injection. Spasticity can be treated by baclofen, which is you can also have a GABA B receptor agonist, and pain medications like TCAs and anticonvulsants can relieve the pain. All right, so let's just quickly go through it. How can we stop the relapse or slow progression by either giving beta interferon, glatiramer, natalizumab? One important thing with the natalizumab is that when you give natalizumab, after administration of this drug, now you will see new lesions on the MRI. New lesions in the MRI with new multiple white matter lesions, hypertense lesions. It is due to, now you might think, hey, it is due to MS. Although we're giving drug, or are we not trying to slow progression or stop the relapse of disease? No, it's actually due to the drug itself. Why? Because natalizumab inhibits alpha-4 integrin. When it inhibits the alpha-4 integrin, so it is associated with progressive multifocal leukoencephalopathy, and that gives the new MRI lesions. So that's one of the important things for natalizumab. Other than that, you also have, you can give, let's just erase a little bit of things here. IV steroids if you have acute flare, for sure, to decrease some inflammation. Spasticity, high yield, baclofen. Spasticity, baclofen, GABA B receptor agonists. GABA B receptor agonists could also be used. And for upper motor neuron lesion, you can give, let's talk about neurogenic bladder here. So neurogenic bladder, for upper motor neuron lesion of the neurogenic bladder, you can give something called oxybutynin. And for lower motor neuron lesion, you want to give something known as muscarinic agonist. And upper motor neuron lesion will give you slow contractility of the bladder. Lower motor neuron lesion will give you flaccid bladder. Okay, let's take a look at this image and move on. So here we have, again, We have fatigue. Okay, one thing for fatigue as well. If the patient has fatigue, we can give some drug known as amantadine. Depression, ataxia, intention tremors. All about cerebellar or cerebellar disease. Ophthalmic, you have optic neuritis, diplopia, nystagmus, INO. All about CN2. Speech, disorthosis kind of speech, against cerebellar problems. Spinal cord, sensory system weakness, spasticity. Again, either the pyramidal neurons, upper motor neuron lesion, basically. Urinary incontinence. Urinary incontinence, we talked about how you will have, if you're an upper motor neuron lesion, how you can have urinary incontinence. And that is all about it. Let's just quickly go through it and move on to the next. All right, MS, multiple sclerosis. It's all about autoimmune inflammation. High yield is type 4 inflammation, in which you have a T cell type and macrophages and forming antibodies. That is all about type 4 hypersensitivity reaction. So multiple sclerosis is an autoimmune disease against the oligodendrocytes, which myelinate the CNS. CNS is all about the brain and spinal cord. It's all CNS, right? So when you knock out your CNS, you're going to get upper motor neuron lesion signs and symptoms. And there are some risk factors, high yield risk factors for multiple sclerosis, in which you have a young female, 20 to 40, with decrease in serum vitamin D levels, which are further apart from the equator, meaning a cold climate, for example, USA, Europe, and also you have smoking patient smokes or EBV, Epstein-Barr virus infection. High yield is they're going to present with optic neuritis, which is a painful eye movements, and you have a dilation of the optic disc. You have some cerebellar syndrome sign symptoms, in which case INO is one of the highest yield, which is intranuclear ophthalmoplegia. Pyramidal tracts are going to be affected because, remember, pyramidal tracts are myelinated by oligodendrocytes. When you knock out these oligodendrocytes, you're going to knock out the pyramidal tracts. That's going to give you an upper motor neuron lesion, which is weakness and spasticity. Spinal cord syndrome, same thing. Here you have a couple syndromes that they can have. Now, high yield is these all signs symptoms are going to be relapsing and remitting, meaning they are going to be episodic, relapsing, remitting, episodic, which is episodic neurological deficits are going to be seen, which are separated in time and space. Findings are on lumbar puncture, you will see increase in IgG levels, and you will also see oligoclonal bands, which are increased level of immunoglobulins within the CSF. Here we have IgG, so that's why we will see oligoclonal bands. MRI is a gold standard. We will see periventricular plaques right here, periventricular on the side of ventricles, and the areas which is the areas of oligodendrocyte loss. Again, the gray matter is gray because of the myelin. So when you knock out the myelin from here on the periventricular side, you will see this space as white because you knocked down your myelin. Okay. For the treatment, you got to stop the relapse or progression by disease-modifying therapy, beta interferon, glatiramer, and natalizumab. Now, with natalizumab, the point is you will see new lesions on the MRI, and that's all due to the fact that natalizumab would inhibit the alpha-4 integrin that causes new neurological things on imaging, which is on the MRI. Okay. And again, if you have acute flare, you can give IV steroids. And for neurogenic bladder, you want to give something muscarinic antagonism, or you want to give botulinum toxin, spasticity high yield. Because they have upper motor neuron lesions, so there will be spasticity. So you want to give baclofen. Just keep in the head, spasticity, baclofen, or GABA B receptor agonists. For the pain, TCA and anticonvulsants can be used. And that is all for MS. Okay, now let's talk about osmotic demyelinating syndrome. It is also called central pontine myelinosis. There is a massive axonal demyelination in pontine white matter, which you can see in picture A. You have a pontine white matter, but there's a demyelination here. And why? The question is why this is developed. Well, it is secondary to rapid osmotic change. So there's an osmotic change. Most commonly, iatrogenic correction of hyponatremia. When you try to correct hyponatremia, that's one of the causes, but also rapid shift of other osmolytes, for example, glucose. So there is an acute paralysis let's just do it this way. Acute paralysis, dysarthria, dysphagia, diplopia, loss of consciousness can cause altered level of consciousness. So here's what we have. When you correcting serum sodium too fast, so the good mnemonic is from low to high, your pons will die. That's called the osmotic demyelination syndrome. From high to low, your brains will blow, which is cerebral edema and herniation, which we will talk about in a later sense. But here, so when you go from low to high, your pons will die. So what is all about? So here, what you have, increase in sodium. When you increase, there's an increased sodium too fast. When you correct the sodium, let's say from low to high, too fast, what's going to happen is that the water will draw to plasma from brain cells. So water draw from brain to plasma. From brain cells to plasma, right? And that causes oligodendrocyte and that's going to cause what simple thing first? Is going to cause dehydration and cell shrinkage. Dehydration plus cell shrinkage, specifically, peripherally in the pons. And that will lead to apoptosis. Apoptosis. And which brain cells we're talking about? When we talk about brain cells, if you can recall, the major about the max cells we have in the brain are all about astrocytes. Astrocytes are the major cells, and then also we have oligodendrocytes. So astrocyte, oligodendrocytes, so they will go into dehydration and they will lead to apoptosis within the pons, peripherally affect the pons. And that is for osmotic demyelination syndrome. Here, the next one is all about your from high to low, your brains will blow. And that is by giving, if you give someone, by giving someone hypotonic fluids, hypotonic fluid, what's going to happen is the opposite is going to happen. Let's just mention here. So the free water gets into the brain. Free water gets into brain. And that free water, when it gets to brain, is going to cause what? Simple. It's going to lead to edema. And that edema will eventually cause herniation. And that will cause cerebral edema herniation. Okay. So let's just review this and move on to the next. So here all we have is, osmotic demyelination syndrome. It is the other name is central pontine melanosis. High yield point is going to be that on the MRI, you will see axonal demyelination in the pontine white matter. If there's a demyelination in the pontine white matter or in the pontine, demyelination in the pontine will give you osmotic demyelination syndrome right away. But you have to know why this happened. Well, it happened because of rapid osmotic change due to correction of hyponatremia rapidly. So there was too low of sodium, and you try to correct it very fast, and that caused the water to go outside from the brain cells into the plasma, that shrunken the brain and lead to dehydration, and that dehydration and cell and also this dehydration peripherally occur in the pons and it leads to apoptosis. That is all there. But also you will also see correction of hyponatremia. It is also specifically seen in alcoholics. Okay, so here this patient is going to present with acute paralysis, dysarthria, dysphagia, diplopia, loss of consciousness. And if they were to have a bilateral pons loss, bilateral pons, if the bilateral pons are affected, they will cause something known as locked-in syndrome. Locked-in syndrome. And if you recall what was locked-in syndrome, that was only that the patient can only have the normal movement of the eye, and everything is just quadriplegia, can't move nothing. Only the eye would move, and that too is just vertical gaze. Vertical gaze, and there's going to be nothing else, no other movement. And that's going to be all for osmotic demyelinating syndrome. Let's move on to the next one, which is acute inflammatory demyelinating polyneuropathy. Most common subtype of GB syndrome, Guillain-Barré syndrome. Again, it is an autoimmune condition that destroys the Schwann cells. So what was the autoimmune condition which destroyed the oligodendrocytes? That's the MS. What is the autoimmune condition which destroys the Schwann cells? And that's the Guillain-Barré syndrome, which is also known as acute inflammatory demyelinating polyneuropathy. Okay, so Schwann cells, why inflammation and demyelination of motor fibers, sensory fibers, peripheral nerves. Again, wherever the Schwann cells are going to be present, again, let's just recall, where are the oligodendrocytes present? They're all present in CNS plus the spinal cord. Where is the Schwann cell present? In the peripheral nervous system. And that is going to be the peripheral nervous system, the motor fibers, the sensory fibers, again with the peripheral nerves. Which are the peripheral nerves? That's also high yield. The peripheral nerves are going to be, again, if you think about the cranial nerves, sometimes you think all of them are peripheral. Either all of them are peripheral or all of them are central, meaning they are within the brain and spinal cord. But only cranial nerve 3 to cranial nerve 12 are peripheral nerves, and cranial nerve 1 and 2 are not peripheral. Okay, so it is likely facilitated by high-yield molecular mimicry and triggered by inoculations or stress. Despite association with infections, example, Campylobacter jejuni, high yield, okay, example, Zika virus, no definite causal link of any pathogen, but this is important as a risk factor, results in high-yield symmetrical ascending muscle weakness, paralysis, and depressed or absent DTRs, which are the deep tendon reflexes, and it begins in the lower extremities. Okay, there's also facial paralysis, usually bilateral, and respiratory failure are also common. May see autonomic dysregulation. Example, cardiac irregularities, hypertension, hypotension, or sensory abnormalities. Most patients would survive with good functional recovery. There's an increase in CSF proteins with normal cell count, and that is known as albuminocytotoxic dissociation, meaning there's an increase in CSF protein, but normal cell count. So there's an albumin dissociation. So albuminocytotoxic, cytologic dissociation. In other words, proteins are high, albumin is high with a normal cell count. Respiratory support is critical until recovery. Disease-modifying treatments, for example, plasma exchange or IV immunoglobulins, are necessary, and no role for steroids. So let's just review this. We have GBS syndrome, which is an autoimmune disease through the molecular mimicry. It occurs following an upper respiratory tract infection, for example, viral Zika virus, or gastroenteritis through C. jejuni infection. Following a febrile illness of these two, there's an autoimmune disease through molecular mimicry. Okay, where's that word? Here. Okay, and that destroys the Schwann cells. The Schwann cells are the ones which are myelinating the PNS. So in GBS, Guillain-Barré syndrome, all we have is a PNS involvement. There is going to be no CNS involvement. Why? Because all CNS is going to be myelinated by oligodendrocytes. So we don't see nothing of CNS, meaning nothing of brain and spinal cord, all about peripheral nervous system. And that would also include high yield point. It's not only include, it doesn't just include the motor fibers, sensory fibers and all that, but also the peripheral nerves. So it includes all the nerves CN3 to all the way to CN12. They're all peripheral nerves. Now, high yield point is this inflammation. This inflammation will affect the endoneural infiltration will occur. And that endoneural means you have a specific a nerve fiber. Each of one of the nerve fibers are there is a sheet around it that's called endoneurium. And that and each nerve fiber will be affected, which is called endoneural infection, and it will be infiltration of what cells? The lymphocytes and macrophages. It's an autoimmune disease, so you will see lymphocytes and macrophages infiltration that destroys the Schwann cells. Now let's talk about some signs and symptoms. It will result in symmetrical ascending paralysis or weakness and absent DTRs until it hits the diaphragm. So it is an ascending paralysis. So from legs all the way towards the arm, but in the middle you have a diaphragm, right? So when you hit the diaphragm, that's going to cause respiratory failure, and that will be seen as decrease in FVC. Okay, so for the treatment purposes, you want to give a respiratory support until recovery is there. Okay, that's important. Other than that, ascending paralysis with absent DTRs are there, and you also have because of all cranial nerves, you have a facial paralysis. You have autonomic dysregulations. You also have sensory abnormalities could also be seen. But it's a good functional recovery is there. Treatment-wise, before we look at treatment, just take a look at LP. When we do the lumbar puncture, you will see increase in CSF proteins. That's high yield again. You increase the CSF protein, but normal cell count. That's called albuminocytologic dissociation. All it means is you have increase in protein albumin than the normal cells. And there is a normal cell count. And other than that, the most accurate test would be your nerve conduction study, which will show you decrease in propagation of electrical impulse along the nerve, and that will show that there is a demyelination there. Okay, and lastly, respiratory support is there, but also the disease modifying treatment, for example, plasmapheresis or IVIG, which is IV immunoglobulins. But since it's an autoimmune disease, there's no role for steroids. And also, because you're doing plasmapheresis and giving IVIGs, they're going to hold up your IgGs so that actually IgGs will be taken up by those inflammatory cells so that they don't destroy the actual nerve, myelin, which is in the Schwann cells. And that is all for this one. Let's move on to the next, which is acute demyelinated post-infectious encephalomyelitis. Okay, here we have multifocal inflammation and demyelination after infection or vaccination. Okay, after infection, remember, look, it's after infection. Which sort of infection we're looking at? For example, measles, varicella, vaccinations or rabies or smallpox. So there's a multifocal inflammation and demyelination either from after the infection or vaccination, and it's going to present with rapidly progressive multifocal neurological symptoms and altered mental status. So the high yield point is all about here vaccination, which vaccinations and which infection we're talking about: measles, varicella, MV, and vaccinations for rabies and smallpox. And that's all for the acute disseminated, which again is post-infectious encephalomyelitis. The next is all about your Charcot-Marie tooth disease. It is also called hereditary motor and sensory neuropathy. So again, as the name mentioned, you have a motor problem and a sensory problem. It is a group of progressive hereditary nerve disorders related to defective production of protein involved in structure and function of peripheral nerves or the myelin sheath. Typically, the autosomal dominant and associated with foot deformities, high yield. where did it go? Pes cavus or hammer toes, lower extremity weakness, for example, foot drop, sensory deficit, for example, decreased vibration, proprioception. Most common type is CMT, which is Charcot-Marie Tooth, right? CMT1A, caused by PMP22 gene duplication, can't move toes. So that's a good mnemonic for the can't move toes for Charcot-Marie Tooth. So just remember, these patients, they can't move toes. So they have a toe problem. Because they can't move toes, they have a toe problem, which is pes cavus or hammer toes. All right, here all we have is as a review. There was a progressive, it's a progressive, again, hereditary, which is autosomal dominant in nature. It's a nerve disorder that leads to defective production of proteins involved in, let's say, function of the peripheral nerve, okay, and or the myelin sheath. So the way you're going to remember this Charcot-Marie Tooth is through this mnemonic: CMT, can't move toes. So here all you will have is a foot problem. So foot deformities, pes cavus, hammer toes, foot drop. The only thing extra is all about sensation deficits, or decreased vibration and proprioception. So you have it. So can't move toes. They can't move toes. So they are going to have two things. They will have foot drop because they can't move toes, and they will see pes cavus and hammer toes. So this pes cavus is a high arched foot. For example, it's going to be like this: high arched foot. It's the pes cavus, and hammer toes are there also. On top of that, you have a sensory deficits, a decrease in vibration and proprioception, and that's going to be all about Charcot-Marie Tooth. Okay, now let's talk about progressive multifocal leukoencephalopathy. It's a demyelination of CNS. It is due to destruction of oligodendrocytes, which are secondary to reactivation of the latent JC cells. If you recall, the JC cells are where? So JC cells, JC virus, my bad, not the cells, but JC virus, it's a polyoma virus, my bad, right? JC virus is a polyoma virus that replicates, important how you point, that replicates within the oligodendrocytes. So when it replicates with oligodendrocytes, it causes what? When there's a reactivation, when there's a destruction of oligodendrocytes, you have a reactivation of the JC virus. It is associated with immunosuppression. Why would you have the reactivation when there's an immunosuppression, right? For example, in lymphomas, leukemias, AIDS, organ transplantation, there's a it rapidly progresses. It is rapidly progressive, usually fatal, predominantly involves the parietal and occipital areas. Visual symptoms are common. Increased risk associated with organ transplantation. Medication, for example, natalizumab. With the rapid progressive, you are going to be thinking about. So here's the thing. So this patient is going to be an immunocompromised patient who might have gone into, for example, lymphoma, leukemia, AIDS, or organ transplantation. It developed a rapid progressive dementia and motor deficits. And that is all due to demyelination of CNS by the destruction of who myelinates CNS? Again, oligodendrocyte. So you're somehow destroying the oligodendrocyte. Now, who is destroying the oligodendrocyte? It is due to the reactivation of the JC virus that is destroying the oligodendrocyte in immunosuppression. Okay, and how you'll point is again about this drug that we mentioned already is the natalizumab. Natalizumab increases the association. It is increase the risk in organ transplantation, and natalizumab, which we talked about how it causes inhibition of alpha-4 integrin, leads to progressive multifocal leukoencephalopathy. Natalizumab is given where? In multiple sclerosis, MS. Okay, so that's all for multiple progressive leukoencephalopathy. Let's take a look at the next one. All right, we have critical illness polyneuropathy. This one is all about axonal degeneration, likely from an inflammatory mediators and microcirculation injury. There was a decrease in nerve excitability secondary to sodium channel inactivation. That leads to symmetrical weakness again, causes proximal more than distal weakness. Decrease in deep tender reflexes, diaphragmatic weakness may lead to difficulty weaning from the mechanical ventilation. So here, all you have is axonal. So see, we did talk about symmetrical weakness, which we also, so let's just do a versus here. We also saw the symmetrical weakness in a GBS, Guillain-Barré syndrome, right? Same thing, symmetrical weakness and decrease or absent DTRs. So here we have to differentiate this polyneuropathy, which is known as axonal polyneuropathy or critical illness polyneuropathy, versus your GBS, Guillain-Barré syndrome. Both are going to have symmetrical weakness, but with the axonal polyneuropathy, all we have is proximal affected more than distal. With the GBS, all we were looking at the lower part, ascending paralysis from lower to the upper limb. But here is the proximal than distal differentiating feature. Other than that, both are going to give the diaphragmatic weakness. But here you also have a decrease in deep tender reflexes, which are the reflexes. But with GPS, you most likely will see absent DTRs, absent deep tender reflexes. On top of that, with the GPS, you will see autonomic dysfunction. For example, hypotension, hypertension, tachycardia. Let's take a look at that. Look here. Autonomic dysregulations are there. Cardiac irregularities, hypertension, hypotension, absent DTRs, although these are depressed as well, but absent is more seen there. Fissure paralysis because of the cranial nerves. But here you will not see anything with the autoimmune dysfunction. On top of that, this is not associated with febrile illness. It does not precede a febrile illness. But here, if you look at the GBS, there is a preceding febrile illness which causes autoimmune disease through molecular mimicry. Okay, and these are some differentiating features versus GBS versus critical illness polyneuropathy, which is also known as axonal polyneuropathy. And that's going to be all for this one. Let's move on to the next other disorders. Here, all we have is the Krabbe disease, metachromatic leukodystrophy, and adrenoleukodystrophy. So the Krabbe disease, it's seen in it's in your biochem, but all this is, it's the deficiency of galactocerebrosidase. That causes beta galactosidase to leading to accumulation of the galactocerebrosidase accumulation within the macrophages. Okay, galactocerebrosidase, beta galactosidase, that's the enzyme, leads to galactocerebrosidase accumulation in macrophages. That's the Krabbe disease. And it's going to affect the oligodendrocytes. So the way you're going to remember this is Krabbe, B for brain. And in brain, you have oligodendrocytes. And that's how you can recall, okay, it's going to affect the oligodendrocytes. The next one is all about your metachromatic leukodystrophy. Here you have the deficiency of aryl sulfatase. So aryl sulfatase, when you have deficiency, causes myelin can't be degraded. So myelin will not be able to degrade. That leads to accumulation of myelin within lymphosomes. Not lymphosomes, my bad, lysosomes. So there's accumulation of lysosomes of myelin, which causes metachromatic leukodystrophy. So here, again, if you think about metachromatic, I mean, you think about it as metachromatic, multi something, right? Multi chromatic or multicolor. So you're going to think about multicolor, meaning it's just a mnemonic, okay? You're going to think about CNS plus PNS affected, CNS and PNS affected, two things, multi, right? Metachromatic, multicolor, CNS and PNS being affected. Okay, and with the leuko, you know, leukodystrophy is there. So you have a CNS and PNS involvement. Then the last one here is all about adrenal, meaning adrenal, leukodystrophy. Adrenals, in this one, we have a very long chain fatty acids that will not be going to the peroxisome. So here's a problem of the peroxisome. So very long chain fatty acids will not be able to go to peroxisomes. When they cannot go into the peroxisomes, so they will accumulate. When these very long chain fatty acids accumulate, they will accumulate in the adrenals and the white matter. So adrenals, which means adrenals, leuko, white matter, so adrenals plus white matter. So they will accumulate there. So just to recall this, we have the Krabbe disease, in which you have a deficiency of galactocerebrosidase, beta galactosidase. Basically, it will accumulate in the macrophages. Important point. Second thing, metachromatic. You have CNS involvement and PNS involvement, in which the myelin would not be able to degrade within the lysosomes. So it will, the myelin will accumulate, causing multichromatic leukodystrophy. The next is adrenoleukodystrophy. Adrenal means adrenal, leuko means white matter. So you have the very long chain fatty acids which normally go to peroxisome, get destroyed there, but now you can't send them there because of this disease. So these will accumulate in adrenals and white matter. And that is going to be all for the other disorders here. Okay, now let's talk about the last thing, which is not mentioned here. It's the subacute sclerosing panencephalitis. Panencephalitis. Now, when we talk about panencephalitis, we mean the whole thing. We mean the gray matter plus the white matter being affected. Panencephalitis, right? Okay. Now here it's a rare complication of measles infection. It is due to its slow but persistent infection of the brain by the measles virus. So it's slow but persistent. When you have a persistent infection causes of the measles virus, it's a complication of that. It occurs usually, so let's just write here, it occurs several years after the recovery from the initial measles infection. Years after the recovery of initial measles infection. This is characterized by accumulation of viral nucleocaspits within the neurons. Which are the gray matter plus the oligodendrocytes, white matter, leads to formation of intranuclear inclusions. Now, important point is you will see intranuclear inclusions that leads to inflammation and demyelination. So it causes more and more inflammation plus demyelination plus gliosis in different cerebral areas. Okay. It causes various, so it causes various neurological deficits and dementia, various neurological deficits plus dementia. And it's progressive and fatal, okay. Because it's a complication of measles, it is progressive and fatal. High titers of measles, so what you will see on if you were to check the titers of measles antibodies, you'll see high titers of measles antibodies in two places, in CSF and serum. And again, if you think about high titers of measles antibodies in CSF, it will give you oligoclonal bands. So let's just recall the whole thing and move on to the next. Here we talked about subacute sclerosing panencephalitis. Pan means gray matter and plus white matter. Encephalitis means brain problem, infection of the brain, inflammation of the brain. Here we have it's a measles. It's a rare complication of the measles infection, which occurs years after the initial infection, years after the apparent recovery from the initial infection, right? And all we have here is the virus nucleocaspids. They would accumulate within the oligodendrocytes, within the neurons, and that leads to formation of intranuclear inclusions, and that causes a lot of inflammatory cells to go there, causes demyelination, eventually causing gliosis in different areas of the brain. So all you have is the various neurological dysfunctions seen in it, plus dementia. Okay, and that is all due to measles infection. Okay, let's review this page. All we have is the first one is osmotic demyelination syndrome. The name says right there, osmotic means something is going on with the osmolytes. Demyelination, again, there's going to be demyelination syndrome. There's a lot of things going to be happening, a bunch of things all together in the syndrome, right? So here all we have is the pons, which will go into demyelination. Okay, so pontine myelinosis is the word here. It is due to correction of your sodium fast. So from low to high, your pons will die. That's a very fantastic mnemonic. From low to high, meaning when you have a low sodium. And why would you have the low sodium? In case of alcoholism, chronic alcoholics have a low sodium, hyponatremias. So when you try to correct that hyponatremia very quickly, that's going to cause osmotic demyelination syndrome, in which case what's going to happen is that sodium that you corrected so fastly is going to cause all of the brain, all the brain water will just go out into the plasma. That's going to shrink the brain, and specifically we're looking at in the pons, because they're going to be affected the most. So when we shrink the brain, the pons, what's going to happen is you have a death of those cells in the pons, leading to demyelination syndrome, and it's going to present with dysarthria, dysphagia, diplopia, loss of consciousness, and that is for osmotic demyelination syndrome. Now, when we talk about GBS, let's just change color. GBS syndrome, we are going to think about ascending paralysis. Let's just do it here. Ascending paralysis with absent DTRs, plus cranial nerve involvement, plus autonomic dysregulation, plus you're going to think about respiratory failure. So it's going to start as ascending paralysis from legs all the way to arms, but when it hits the diaphragm, it's going to cause respiratory failure, which is going to be seen as decrease in FVC. And it occurs preceding there's an infection. So there's an infection, febrile infection from C. jejuni or the virus, upper respiratory tract infection like Zika virus, which causes molecular mimicry, causes autoimmune destruction of the Schwann cells. Schwann cells are in the peripheral. So all you have in GBS is the peripheral nervous system involvement and no CNS involvement. And why no CNS? Because you know the CNS is myelinated by oligodendrocytes, so nothing there. Okay. You will see increase in CSF proteins. You can give plasma exchange, which is known as plasmapheresis, IVIG, which is IV immunoglobulins, no role for steroids. Then you want to compare this versus your critical illness polyneuropathy right here, which is also known as axonal polyneuropathy. In this, why are we doing comparison? Because both of them are symmetrical weakness, but here we have proximal weakness more than the distal. That's a very important point. On top of that, there is no autonomic dysfunction, so that you will only see with the GBS. On top of that, you will only see a preceding infection like C. jejuni infection with GBS. Okay, and here with the critical illness polyneuropathy, all you have is decrease in DTRs, and diaphragmatic weakness is also there. Okay. And now looking at the next one is about your acute disseminated post-infection encephalopolymyelitis. My bad, encephalomyelitis, not polymyelitis, but encephalomyelitis. This is all about, again, acute disseminated post-infectious, meaning that infection disseminated, which causes encephalomyelitis, right? All we're going to think about infection. Which infection are we looking at? We are looking at measles, and we are looking at varicella. what are the vaccinations that we might be looking at? We might be looking at rabies vaccination or smallpox vaccination. All of them will cause encephalomyelitis, which is rapid progressive multifocal neurological symptom with altered mental status, but highly linked in infection and the vaccination. The next is all about Charcot. Let's change color. Charcot-Marie tooth. The mnemonic is can't move toes. With this autosomal dominant hereditary disease, what we are going to be looking at is foot problem, can't move toes. So foot drop, pes cavis, hammer toes, and also sensory deficits. So anything with the foot, Charcot-Marie tooth, can't move toes. Here, the next one is progressive multifocal leukoencephalopathy, is the demyelination of a central nervous system. When we talk about CNS, we talk about oligodendrocytes. Why? Because progressive multifocal leukoencephalopathy will be seen with immunosuppression. Immunosuppression causes the latent JC virus to reactivate, that destroys the oligodendrocytes, right? It is predominantly involves the parietal occipital lobes, increased association with, why would you have immunosuppression? Like, for example, you have lymphoma, leukemia, AIDS, or organ transplant. So here, organ transplant medication like natalizumab. Natalizumab inhibits alpha-4 integrin, which causes progressive multifocal leukoencephalopathy. We talked about this one, but the last one here is the Krabbe disease. Krabbe is the brain in which we have the macrophages, accumulation of things in macrophages, metachromatic leukodystrophy. There's an accumulation within within the lysosomes, and we have adrenoleukodystrophy, accumulation within the peroxysomes. And that's all for this. Okay, now let's talk about neurocutaneous disorders. So neuro means your brain and spinal cord. Cutaneous means what? Skin. But on top of that, you also think about bone. Okay, so all these disorders are going to be based on things that are going to be either in the brain or spinal cord, nor skin or bone. Okay, these are all the neurocutaneous disorders. So let's talk about the first one. Is called Sturge-Weber syndrome. Now this is okay. One more thing. Okay, these all are autosomal dominant. If you think about it, except they're all autosomal dominant except the first one, which is congenitally non-hereditary anomaly of the neural crest derivatives. So if you look here, AD, and AD, all are autosomal dominant except the first one. Okay, that's important. Other than that, you want to just let's talk about it. Okay, it is congenital non-hereditary anomaly of the neuronal crest cell derivatives. There is a somatic mosaicism of an activating mutation in one copy of the GNAC gene. So we got to know the normal. What is GNAC gene doing normally? Well, normally it is stabilizing. It stabilizes the capillaries. Okay, it stabilizes the capillary. So what's going to happen is, so when you have a mutation in the GNAC gene, now you cannot stabilize capillary. When you cannot stabilize the capillary, guess what's going to happen? You have bleeding, right? You have bleeding. So let's look at the presentation now. Capillary vascular malformation. Well, because you can't stabilize capillary, guess what? You have a malformation of the capillary, right? But importantly, what's going to lead to is called port wine stain high yield. Port wine stain. Take a look at this picture. Port wine stain. Wow. Right? Port wine stain. Important. Let's just highlight this part. Port wine stain, which is Navis flamus, or non-neoplastic birthmark. Okay, in CNV1 or V2 distribution, basically on the face distribution, right? The second thing is ipsilateral leptomeningeal angioma, right? Again, angioma is all about what? Capillary, right? With calcification, high yield. So that will lead to seizures, epilepsy. Okay, so what is leptomeningeal angiomas? Leptomeningeal capillary angiomas, meaning capillaries again involved here, which will give you, like, the important thing is tram track calcifications, which are here. Calcifications will be there. The next part is all about you will see episcleral hemangioma. Again, episclera, in the sclera you will also see hemangioma, because again the capillaries and wall leading to hemangioma, which would cause increase in intraocular pressure, which leads to early onset glaucoma, because you have increase in IOP, intraocular pressure. Now, Schrug-Weber is also called encephalo-trigeminal angiomatosis. Okay. Now let's look at mnemonically. How can we figure this out? It's a Sturge-Weber syndrome, right? So the capillaries are like webs. Capillaries are webs, right? So let me just draw them some. So what are these? These are like webs, right? So in the Sturge-Weber syndrome, you're affecting the capillaries. When you're affecting the capillary malformation will occur, which will give you port wine stain, which is a birthmark. It will lead to leptomeningeal capillary angiomas and episcleral hemangiomas. Okay, and that's all about this disease. All you got to know is gene is stabilizing these capillaries, and we knock this out. You can't stabilize capillary. When you can't stabilize capillary, you're going to get a port wine stain. You are going to get leptomeningeal angiomas, and you're also going to get episcleral angiomas. Moving on to the next one, we have tuberous sclerosis complex. Now, tuberous sclerosis, it's a variable expression, mutation in the tumor suppressor gene, tuberous sclerosis C1 on chromosome 9, which normally encodes for HEMR10, okay, or tuberous sclerosis C2 gene on chromosome 16, which encodes for tuberin. Pronounced tuberin, so you would know tuberous sclerosis C2. Let me erase this so you can have a better view of it. Tuberous sclerosis, TSC2, tuberous sclerosis C2 for tuberin. So you know the 2 encodes for tuberin. Here, all you have is with tuberous sclerosis, so TSC, right? So TSC1 and TSC2, one being encodes for HEMR10, second encodes for tuberin. Okay, and what are these? What are these two things? They are tumor suppressor genes. So when you knock out your tumor suppressor genes by mutation in these genes, now you can't stop a tumor, whatever they're present, right? Because you knocked out your tumor suppressor genes. So here you will have hematomas in CNS and skin. Let me erase capillary up top. Hematomas in CNS, skin, angiofibromas. Let's take a look at angiofibromas and ash leaf spots, D, and renal angiomyolipoma. So here, picture B, first of all, let's take a look at this. It's the leptomeningeal. It was the leptomeningeal angiomas with calcification. You can see some calcifications here, right? Okay, that's the white thing is all about calcification. So that's there. Picture C is the angiofibromas. Angiofibromas. They look like acne, right? But they are not acne. It's angiofibroma. They're high yield associated with tuberous sclerosis, right? Let's take a look at ash leaf spots. Here's on picture D, you have the ash leaf spots. What are the ash leaves? If you look at normal and you have a hypopigmentation, sort of a leaf-like ash leaf spot, hypopigmentation. Okay. Ash leaf spot, hypopigmentation. Okay. And then you have two myomas. For example, you have a cardiac rhabdomyoma and renal angiomyolipoma. And that's also important that these two myos are there. Okay. And then you have seizures and Shagreen patches. Okay. Increased incidence of subepidermal giant cell astrocytoma and angle fibromas. Fungal fibromas are just on the fingers. You have fibromatous lesions like outgrowth, and that's called fungal fibroma. Okay. Now, how do we remember this one now? With this one, you're just going to think about that. First of all, let's figure out a couple features here. With the pictures, you just have to somehow memorize, okay, when we think about this angiofibroma, acne-like, they're not acne, but acne-like spots, you are thinking about tuberous sclerosis, Ashley spots, tuberous sclerosis. Okay, these two things are just with the image you can right away tell. Picture E is telling us about renal angiomyolipoma. Let's take a look at that picture E. Here, it's a renal angiomyolipoma. Look at all these fats. Okay, so angiomyo, within the muscle, you have the lipomas. Fats are accumulated. And that, okay, how do you know this is fat? Okay, whenever we take a slide, right? We take a slide, we put it under the microscope, we wash off. When we wash off, the fats get washed off. When the fats get washed off, all we see is just empty circles, clear circles. When we see the clear circle, we think about, okay, this is the fat. So this is lipomas here. So it's angiolipomas, angiomyolipoma within the kidney. It is the within the muscles. It includes the muscle, and myo is a muscle, lipo means again the fat. So it is within the angiomyolipoma, within the blood vessels, the muscles, and the fats are all accumulated within the renal, within the kidney. So it is the renal angiomyolipoma. Okay, so how do we remember all of that? Now, the easy way to go for it again is the myo, right? And myos are, if you think about a muscle, right? A muscle has a tubules, right? Muscle has what? If you recall, muscles have tubules. So tuberous sclerosis, tubules for tuberous sclerosis. Somehow, I mean, this is one of the mnemonic that you can go for, that you have myo muscle with the tubules. Muscles have tubules, and that's why it is seen in the tuberous sclerosis. And why is that important? Because these are not going to be seen anywhere else. So you just have to memorize these on top of your head, that you see myo, either in the cardiac and the renal. You're going to think about a tuberous structure, tuberous sclerosis. Okay. If you see angiofibroma, you will also think about this. Ashley spots, you also think about this. And angiomyolipoma, also think about this. These are just there. But one mnemonic is this tubule, as it might help you with it. Again, the second mnemonic was C2 for tuberin and C1 for hamartin. Both are tumor suppressor genes. Okay, let's look at the next one, which is the neurofibromatosis type 1. So NF1. It is autosomal dominant, 100% penetrance. Mutation in NF1 tumor suppressor gene on chromosome 17. Again, NF1. There's a mutation in NF1, which is a tumor suppressor gene on chromosome 17, which encodes for, so what normally encodes for what? Neurofibromin. Normally, neurofibromin, it inhibits the RAS regulator. So it's a negative RAS regulator, meaning it inhibits. So normally, neurofibromin inhibits RAS. So again, normal. Let's think about normal first. Normal NF1 encodes for neurofibromin, which inhibits RAS regulator. This is all a tumor suppressor gene. But here, you knocked out your NF1, which is a tumor suppressor gene, which encoded for the RAS regulator. So now you have unregulated growth. And that is seen how? They're seen as cafe-late spots. Cafe-late spots are, let's take a look first. Cafe-late spots. Let me zoom in here. This is the cafe-late spots. You have an hyperpigmentation, macules, hyperpigmentation, right? Hyperpigmentation, a hyperpigmented macules, seen after birth. Seen after birth on the trunk. So what is this space? This is trunk, right? So seen after birth on the trunk, and it increases the risk of CNS neoplasm. That increases the risk of CNS neoplasm. Okay, this is one thing. It is a hyperpigmented macule. On top of that, not only cafe-au-lait spot, but we also have intellectual disability. Important thing is this: cutaneous neurofibromas. Here are the cutaneous neurofibromas. These are all cutaneous neurofibromas. What are they? They are just soft, multiple. So they're soft. They're multiple, fleshy, benign tumors. Okay, which comprised of Schwann cells. Schwann cells. Now, importantly, they increase in size. They increase in size and numbers as age increases. So with increased age, if you look at this patient, okay, might be a younger adult or a little older adult, you see how many cutaneous neurofibromas are there. Neurofibromas. Cutaneous means just on the skin. Well, you see they're increased in size. So as you age, they're also going to increase in size and also increase in numbers as you age. So that's the cutaneous neurofibromas. You also have lich nodules, which are pigmented iris hematomas. Let's take a look at that. Picture H. Take a look at this. You have pigmented nodules within the iris. Now, you want to differentiate this versus Kayser-Fleischer rings. And that, again, the pigment color is almost the same, brownish sort of a color. But that's going to look like a proper ring on the side. But here, and that's going to be seen as a Kayser-Fleischer ring on a slit lamp examination. But here, all you have is you have just pigmented nodules, spots, you can call it, on the pigmented spot that is known as lich nodules, pigmented spots on the iris. They are the hematomas. Then you have the optic gliomas, pheochromocytomas, high yield. Again, see your focal neurological signs, often from meningioma. Bone lesions also there. Sphenoid dysplasia. It is also called von Recklinghausen disease. 17 letters in von Reckling, and you can memorize that mnemonic if you want, but better than that, just somehow we can memorize it, and that's, let me tell you the way now, and that is all about, you're going to think about NF1, which is neurofibromatosis 1. Okay, with the one thing you are going to think about, cafe-au-lait spots. And what was the cafe-au-lait spots? Those were the hyperpigmented, again, look here, hyperpigmented macule. You are going to think about cutaneous neurofibromas, cutaneous neurofibromas, which are right here, right? Cutaneous neurofibromas. You will think about some lich nodules, which is within the iris, okay? And other than that, the important thing is all about your pheochromocytomas, okay? Pheochromocytomas. And that's going to be all for NF1. Now let's differentiate with NF2, which is neurofibrosis type 2. Here we have NF2 mutation for sure. Again, they're again the tumor suppressor gene. But here NF2 encodes for myelin. NF1 was encoding for neurofibromin. You got to know these, okay? NF1 neurofibromin. Again, why neurofibromin is easy. For the one, you're going to think about, look, neurofibromatosis, so neurofibromin. Here, you're just taking out the word neurofibromin, myelin. I mean, you just got to know myelin, okay, here. Same thing goes with the TSC1 and TSC2. TSC1 hemar 10, TSC2 tuberin, okay. But NF2 is doing the myelin, right? Encoding for myelin. And what was myelin used for? So it encodes the myelin. Normally, now let's talk about normal first. So NF2 encodes for myelin, which is used for cell signaling normally. So when you knock this out, let's do this. You knock out this NF2, you knock out your tumor suppressor, which is myelin. Now you're going to have a problem in cell signaling. And in the cell signaling, with NF2 being there, you are going to be thinking about something called NF2 has fewer cutaneous problems. Fewer cutaneous, like here, if you look at NF1, you have so many cutaneous things. So cutaneous is a lot over there, but here you have a few cutaneous, and it majorly presents with CNS. Okay, here high yield point is going to be bilateral vestibular schwannoma. Okay, well, and why is that? So let's take a look at this. NF2 affects 2 ears and 2 eyes. So it runs near. If you remember your cerebellopontine angle, and if you recall your schwannoma, which is the tumor of the Schwann cells, it would lead to compression of the cerebropontine angle, right? And what was running in that cerebropontine angle? So near to that, you had cranial 5, 7, and 8. If you recall, again, your cavernous sinus, you had the Schwann cells. Schwannoma is there because of a vestibular cranial nerve 8 enlargement leading to schwannoma. And bilateral schwannoma is always associated with 2. The way the mnemonic here is going to be cerebello, 2 L's, right? Cerebellopontine angle. So LL for neurofibromatosis type 2. But here all you have is you have a problem as a C in 5, 7, and 8. With the 5, you knock out your 5, what's going to happen? You will have a facial problem, like, right? Cranial nerve 5, trigeminal nerve, facial paresthesias, or facial muscle problem, right? With the cranial nerve 7, knock out that one, you're going to get facial sensation problem. With the cranial nerve 8, all you have is sensorineural hearing loss and tinnitus. So these are the extra things. But here, all you're going to think about with the 2 messing up, causing bilateral vestibular schwannoma, juvenile cataracts, meningiomas, and ependymomas. So meninges, mass in the meninges, mass in the ependymal cells, juvenile cataract, and mass in the CN8, which is the schwannoma, but bilateral. High yield is bilateral. So 2 things. Okay, that's how we said 2 things, right? We said NF2 affects 2 ears, bilateral vestibular schwannoma, 2 eyes, because it is affecting your CN7 and CN5. And also 2 parts of brain. You can just add one more, 2 parts of brain, which is meningiomas and ependymomas. Okay. And the last one, we have the von Hippel-Lindau's disease. Von Hippel-Lindau is the autosomal dominant deletion of VHL gene on the chromosome 3. VHL is, again, von Hippel-Lindau. So what was normally von Hippel-Lindau doing? Well, VHL normally ubiquinates hypoxia-inducible factor IA. Let me erase this part. Hypoxic-inducible factor IA. So normally it's ubiquitinasing, meaning it's adding the ubiquitinase on it so it can get destroyed, leading to degradation of this, right? Protein degradation. That's normal. Again, VHL is doing what? It's putting the ubiquitin on hypoxic-inducible factor A, IA, and leads to protein degradation, leading to degradation of this. When you knock this out, when you knock out this, there's a deletion of VHL. You knock this out, now you have a lot of hypoxic-inducible factor IA, right? And that's going to hemangioblast formation. So here you go. Hemangioblastomas will be seen. What is hemangioblastoma? It is a high vascularity with hyperchromatic nuclei. Let's look at the picture I. Picture I, we have hemangioblastoma with high. So look at all these vascular things. So high hyperchromatic nuclei, highly vascular with hyperchromatic nuclei in the retina, in the brainstem, in the cerebellum and spine. J is the spine. Let's look at J. You have the J there in the spine and also in the cerebellum, right? Brainstem, cerebellum, and spine. So you got to know this hemangioblastoma all over the place in retina, brainstem, cerebellum, and spine. What is hemangioblastoma? Hemangioblastoma. It is in a high vascular region with hyperchromatic nuclei. Seen here, hyperchromatic nuclei with the highly vascularized area. On top of that, you also have angiomatosis and bilateral renal carcinomas. High yield is this. You have a bilateral RCC, renal cell carcinoma. Now the question might arise, what sort of renal cell carcinoma you're gonna, which will arise with this, with the VHL, von Hippel-Lindau disease? That's gonna be the clear cell type. Clear cell type. And we'll talk about the mnemonic here. And then also pheochromocytoma is also seen within this. The mnemonic is HARP. HARP for hemangioblastoma, A for angiomatosis, R for renal cell carcinoma, P for pheochromocytoma. So how can we memorize HARP now? So instead of calling it von Hippel-Lindau, we can call it von Harp-Lindau disease. Von Harp-Lindau disease. Von Harp-Lindau disease, H for hemangioblastoma, A for angiomatosis, R for RCC, P for pheochromocytoma. That's for the von Harp-Lindau disease. Okay, numerous tumors. Again, we talked about all those tumors. They're all benign and could be also malignant. Benign and malignant. Now, their VHL is 3 letters, chromosome 3 high yield. 3 letters, again, high yield because it is associated with RCC. So they will ask you on RCC, it is an inherited disease, autosomal inherited disease that causes RCC. Now, what chromosome does the gene on or does the lesion on? Well, VHL gene is on chromosome 3, so chromosome 3 is affected. So the easy way to go for is RCC is 3 letters, VHL is 3 letters, so they're all associated. RCC, VHL, 3 letters, chromosome 3. Okay, and that is going to be what we have. On top of that, let's talk about one extra thing here. Is the treatment. Treatment for von Hippel-Lindau is surveillance screening for associated malignancies, okay, and resection of identified tumor. So you would do a surveillance screening for associated malignancies, and you will also have a resection of the identified tumor. So let's just quickly go over these. Let me erase this so it will be easy to go through. All right. So the first thing we have, again, neurocutaneous disorders, right? Neuro means brain. Cutaneous means, again, not only brain but spinal cord, but cutaneous means skin, but also you think about bone being present there. So all of them are going to be associated with brain and cutaneous problems. So here, the first of all is the Sturge-Weber syndrome. Webs are the capillaries. So here, the capillaries, they have a problem in the capillaries. So first of all, one more thing is, all of them are autosomal dominant except the first one, which is just the non-hereditary anomaly of neural crest derivatives. GNAC gene encodes for the capillaries. So for the stabilization of capillaries, when you have a mutation in the GNAC gene, you can't stabilize capillary. When you cannot stabilize the capillaries, the webs, right? Capillaries are the webs. So you are going to have a capillary vascular malformation, Port Weinstein, leptomeningeal angiomas with calcification, and episcleral hemangiomas. The next is tuberosclerosis. Tuberosclerosis. There's a TSC1, which encodes for hemartin. Don't worry about hemartin, just know the second one. 2 for tuberin. If you know the 2, you would know the first one is hemartin. Okay, and these guys are they're the tumor suppressor genes. So when you knock out your tumor suppressor genes, you're going to get hematomas all in the CNS and the skin. So neurofibromas, ash leaf spots, rhabdomyomas in the renal and in the cardiac, and the mnemonic for that is myos, or in the muscle you have the tubules. So tuberous sclerosis has all the myomas, for example, rhabdomyomas and renal and angiomyolipomas. The next is NF1. Well, the NF1 is all about it's a major. So NF1 is being the major one thing. NF2 is sort of a minor sort of a thing. Why? Because NF2 only majorly it presents with CNS things and few cutaneous things. But NF1 is as a major, like when you think about one. Okay, one more thing here, the cafe late spots. How are you going to remember this is one? So you want the number one coffee, right? You want the number one coffee, or you want to go to number one cafe, right? So cafe late spots are associated with NF1. You want number one coffee, right? Cafe late spots. You want to go to number one cafe. Cafe late spots, which are just simple hyperpigmented macules. On top of that, you have a lich nodules, which are again pigmented iris hematomas, and also you have pheochromocytomas. And high yield is again the third one is cutaneous neurofibromas. So NF1 is all about coffee, cutaneous neurofibromas as well. What are cutaneous neurofibromas? Again, they are just soft, multiple fleshy, benign tumors, compromise of Schwann cells. Okay, that's the NF1. Now the next one is all about NF2. We said that there are few cutaneous but CNS things are there. In quote for Merlin. Again, Merlin is doing the cell signaling. When you knock this out, you can't have cell signaling. When you can't have cell signaling, you're going to have a bilateral schwannoma. Two things, everything two. 2 ears, bilateral schwannoma, 2 eyes, V5 and V7 affected, and also 2 things in the brain. NF2 affects all 2 stuff. 2 ears, 2 eyes, 2 things in brain, meaning meningiomas and ependymomas. The last one is VHL, von Hippel-Lindau. Instead of calling von Hippel-Lindau, call it von Harp-Lindau disease. Von Harp-Lindau disease is all about chromosome 3 letters, VHL, 3 letters, right? It causes RCC, bilateral, causes pheochromocytomas, angiomatosis, and hemangioblastoma, which is all mnemonic for HARP. High yield in RCC, it causes clear cell type of RCC. And there are 3, it is on chromosome 3 associated with RCC. Okay, and that is going to be all for neurocutaneous disorders.